Let's talk about bronchial hygiene. Bronchial hygiene is defined as the use of non-invasive techniques to help mobilize secretions and improve gas exchange. The idea is that we can tell you as licensed providers how to most rapidly identify the disease and or respiratory symptomology indicates a need for specific techniques to be used in order to improve mobilization secretions. Now the idea is that not only can you do it, but you can actually encourage the patient to self-manage these modalities. Normal clearance requires two things: a patent airway and a functioning mucociliary elevator. Effective cough can more effectively move secretions from the lower airway to the upper airway than anything else you do. So again, no matter what you're doing, including this, is meaningless unless the patient can cough. Okay? So normal clearance. Abnormal clearance is abnormals of the airway, mucociliary function or strength of the breathing muscles. Cough reflex can lead to mucus retention. Mucus plugging can lead to what? Atelectasis, pneumonia, hypoxemia. Okay, normal cough process. Patient will be able to inspire enough volume and to forcibly expel excess secretion of the trigger bronchial tree. When I'm coughing normally, take a deep breath in, show the cough. Very forcefully to mobilize secretions effectively. And when I cough, the diaphragm is pushed upward, pushing the lungs to expel completely. If I can't clear secretions effectively, gas exchange is impaired, becomes impossible. Can ultimately cause lung damage, such as atelectasis. Now, what can affect normal clearance? We talk about COPD, right? Emphysema, lots of tissue elasticity. And forgive me, what's your name again?
Ketoria.
Ketoria, okay. Thank you for remembering lots of tissue elasticity. Nobody ever remembers that, so thanks for remembering that. Okay. And I think it's Kathy, right? Remember bronchitis earlier, the increased secretions, so thank you for remembering that. So again, emphysema, bronchitis, bronchiectasis. Anybody remember what bronchiectasis was? Abnormal widening of the airways that leads to increased secretion production. Okay, infrequent infection. Atelectasis. With atelectasis, typically I lose a lung globe or a lung field. You'll see a whiteout. Okay, again, I have secretion here in the lung that's completely full of fluid. So when that happens, there's no air at all in it. Pneumonia, CHF. CHF is usually related to what? Heart failure. Right side heart failure, right? Okay. Other respiratory infections that produce secretions. Additionally, other conditions may result in need for bronchial hygiene therapy, may be considered a neuromuscular disease like ALS. Amyotrophic lateral sclerosis, otherwise known as what? Lou Gehrig's disease, right? Okay. Paraplegia, quadriplegia. So again, also your stroke patients. Yeah, stroke patients, again, have issues with clearance. I can vouch for it because I'm a stroke victim. So again, for your stroke patients, again, you have what's called hemiplegia, as an example. So the diaphragm still works, only half of it. Like in my example, I have hemiplegia on the left side, so the left side of my diaphragm doesn't work well anymore. So again, I can't cough and clear, so I'm always having to take deep breaths, work with my muscle trainers like this at home. Keep retrain my diaphragm to work effectively. So again, you have stroke patients, assess their breath sounds, and you're able to cough frequently. If not, you're going to see pneumonia. Those patients very frequently. So again, bronchial hygiene is very important with not just your COPD patients, but again, anybody with any type of neuromuscular deficit. So again, any condition that causes a weakened, deconditioned state, reduced ability to cough effectively. General indications for needing therapy. Copious amount of secretion of the poor cough effort. So we've all heard that patient walked in the room and again you heard that rattle, right? They can't cough and clear. All right, so again, low SATs, low pulse ox with lung infiltration upon auscultation. So again, if you get low SAT and your patient does pulse ox, if you don't immediately pull out your stethoscope and listen to the lung field, lungs, you're not doing your job. If you see a SAT, low SAT, second thing you do, pull out your stethoscope, listen to the lung field. frequent, loose, and effective cough. You've got that patient that's coughing real frequently, can't seem to clear it. Loose. You've got rales, bronchi. Labored breathing pattern. Labored breathing pattern with tachypnea, tachycardia. Okay, now again, how do I know if they're tachycardic? What am I going to do?
I'm sorry, what was the question?
And say I had tachypnea here, again, increased respiratory rate, but how do I know if they're tachycardic? Goes back to my assessment, right? Take the pulse, right? For example, touch the patient, not the pulse ox, I want to take the pulse manually, right? Okay, so tachypnea, I can tell by what? Just observe the work of breathing, right?
Breathing, yeah.
Right, so again, goes back to that assessment. Lack of mobility. Goes back to any of my patients. They can be that post-operative patient, it can be that patient that's had a stroke, it can be that patient that's had a hip replacement. So again, I don't think about pneumonia when a patient has a broken limb, do I? Anything that impairs mobility can lead to pneumonia, regardless of the disorder. You had a fracture, it hurts to move. I don't want to move, leave me alone. So again, 5 days in bed for a broken hip, broken leg, 24 hours, I'm at risk for pneumonia if I'm one of these elderly patients. So again, keep that in mind. Anything post-operative. We've all had that little old lady that went in for surgery, broken hip, doesn't want you to bother, don't want you to move her. Every time she moves, she goes, leave me in bed. I'm going to sit here until I feel better and feel like doing something. High risk for pneumonia. So anything post-operative. Diagnostically, that chest x-ray can give a good indication. Of course, when I can't do the other assessment process. If I suspect pneumonia again, that can also be an indication. If they were just...
I want to share something.
Go ahead.
On number 4 there, labor breathing patterns, and this is a true story, probably about a month or a month and a half or so ago, one of our facilities asked me to come and assess a patient. Previously, she was not a respiratory patient. She'd been in their facility for about 2 years, and so all they told me was she didn't look right. So I went in, and in doing the eyes on, there's different respiratory patterns, and so actually she had Cheyne-Stokes. Cheyne-Stokes respiratory pattern. So that was something that needed to be documented. I'm sure something she's had more than 2 weeks ago when somebody decided she looked funny. So pay attention, while you're doing all this assessment stuff. In those Cheyne-Stokes and Cosmos and some of the others, they're actually going to have a period of not breathing, right. Maybe longer, maybe progressive, or it may just be a short thing. But so look at your respiratory patterns, online or wherever you have a reference material, and let that be one of your observations while you're in there doing the not just, oh, she looks funny. It doesn't work like that. Thank you.
That's where that 5-point assessment is critical, like Ray said. Again, it's that holistic look at the patient, everything. Because it's not enough just to put a pulse ox. Somebody says SAT's 88. Okay, I'm gonna panic and go get some O2. But again, again, they're having Cheyne-Stokes reservations. So again, they may have that labored breathing and that period of apnea. Again, that's an indication of what? Again, the patient's in critical compromise, right? I'm not just calling the doctor. I may be dialing 911 at that point. So you have modalities that some of these will apply to you as nurses. Some of these will apply to your RT, be on site. So these will be where we refer that rehab involvement. Okay, some of our more routine modalities in this environment are going to be chest percussion therapy, postural drainage. Those are going to be things that are done by your either respiratory therapist or your physical therapist or your physical therapy assistant. Acapellas, like these devices. Have you guys seen any of these in the building? Okay. These are neat devices. What they do, they create an oscillatory effect when the patient exhales through it. So again, unfortunately I don't have enough flow to drive this one, so let me use the low flow. You have 2 different types, a high flow, green, and a low flow. Low flow for people like me with impaired respiratory effort. That's what you see most of your patients use. What it does, it creates an oscillatory effect which causes vibration in the chest wall, which causes secretion to break away from the the wall of the airway, so the patient can actually cough and clear the airway once it's broke apart. Okay? Then, of course, go ahead.
On these devices, if the patient gets an order for one, don't just take it in there and assume that they start blowing. These are actually adjustable.
Right.
Okay? The end of this turns. So what you're ultimately trying to do is, because everybody's not going to breathe at the same flow rate. So as they're exhaling, you want this to start vibrating. Okay? Once it starts vibrating, that's good. But they need to feel it down here. So initially, when they're exhaling, you're going to feel some vibration. You ask them, put your finger there, can you feel it down here? If they say no, then you're going to make an adjustment, and that's going to increase that vibration until the point that they say, oh yeah, I feel it down there. And chances are, as soon as they start feeling it, they're going to start coughing. Okay? So don't just hand it to them. They need to be set for that patient.
Your job is going to be primarily your RT and your occupational therapist, or we want to train the patients how to use these effectively. So they'll be, as Ray mentioned, they'll be the ones actually reaching that point of proper resistance to create the oscillatory effect, the vibration. Your job is going to be to make sure that the patient uses it. So again, not just when, because the goal of this is for self-management. So the goal is, again, find those proper settings where the patient can achieve effective clearance. Then that's complement beat I mentioned earlier, making sure that when you go to the patient's room daily, multiple times during the day, say, hey Bob, do you use your acapella today? Hey Bob, don't forget this. So again, your RT, your occupational therapist will be the ones that actually go in and set it up, train the patient on initially. Your job is to be the complement beat, make sure they do it. Now, all these modalities are actually meaningless without the last one, cough. So, we're going to be reviewing your rehab team. Again, effective chest percussion and postural drainage. Make sure that it's actually in their school of practice. They've learned this in school, but again, it's not something you do daily. Again, when we think PT, we think about ambulation, right? Strengthening, things of that nature. So again, the airway management, when it comes to clearance, something that will be resurrecting for them. So it's going to be something that, again, as a nursing staff, the cop on the beat, and the RT, that's going to be seeing these patients daily and assessing them, that we may be referring to those patients to rehab for assessment for these modalities. We mentioned the acapella. Now, the good thing about the acapella, too, when your RT starts assessing your patients and making recommendations on these devices, it may be that when you're delivering the neb therapy, we actually have it done with the neb, with each neb treatment, which maximizes the effect because it does a couple things. One, with the introduction of the neb, introduces humidity, which does what? Helps liquefy secretions, right? Which makes the mobilization even easier. Also helps, again, with the delivery of the bronchodilator, which helps dilate the airway. It's a combination of airway dilation plus liquefaction secretions makes it easier to mobilize secretions. The goal with these devices, again, is that self-management at the end of the day. Here's the indicator for typically my bronchitic patients with emphysema, those are bronchiectasis. Who can do it? PT, occupational therapy, respiratory therapy, and nursing. Who are we going to see actually implementing it typically? With the breathworks program, it's going to be typically your RT that starts it, or your occupational therapist. Who's going to be my cup on the beat, make sure it happens? Raise your hands. It's going to be you, right? Because again, my educator, my occupational therapist, my RT is going to be reinforcing the technique, teaching it, implementing it. Then it's going to be your job to help make sure it happens. Spirometry.
That's a device from hell. Sorry.
Go ahead. Okay, Kathy. Good. I like answers.
Well, I had COVID back in October, and they told me that I had to use one of those
Right.
to get well. That was the hardest device I've ever had to use.
Why?
Because after having COVID, it was hard to fill my lungs up and get that
Right.
bubble up where it needed to be and keep it there.
Okay. Let's talk about COVID then. With COVID, it's primarily a what process? We talked about earlier. Inflammatory process, right? So again, with that inflammation, you had what? An obstruction, right? Made it hard getting air.
I also had double pneumonia.
But there you go. So again, you had a lot of compromises there. Okay, so now how did they tell you, what goal did they tell you to achieve with this? Do you remember?
No, I don't.
Okay. Now, with every one of these devices, now Ray, I think you got a chart, don't you? So with every one of these devices that comes with a nomogram in the package, piece of paper. Again, by age and height, it tells you what you should achieve with goal sampling. So you're not going to go in and just hand this to the patient.
No.
So what you're going to do is you're going to pull that nomogram out of the package, or you're going to use one of our handy-dandy laminated ones. It's going to tell you by age and height and gender what your goal should be. So for me, I'm 5'4" and a half. I tell my wife, because she's 6 foot, 5'4" and a half. And with my age, I'm 53. I should be able to do easily about 3 liters or 1,000 mLs, right? Now, I also told you I'm compromised. I have hemiplegia. My left side diaphragm doesn't work. So again, my goal should be 3 liters here. So again, when I instruct the patient to use this, exhale completely. Here, deep breath. Now you want to take a nice slow deep breath, maximize the inflationary process. Also you have a coach here on the side. What the coach do? The coach encourages you to take a nice slow deep breath. You don't want to peg it right up there. You want to make sure you take a nice slow, because if I take a fast breath, I'm going to inadvertently peg the coach here. But I'm not going to achieve my goal over here. So the slower the breath, more likely I can achieve my volume requirements here. So now watch me again, ladies. So slower the breath, the higher I get to my goal volume, right? So again, let's start with the process again. Fully exhale the breath, clear the lung fluid, the volume. I've set my goal. Mouthpiece to the mouth, nice slow deep breath, watch the coach. Slower the breath, larger the volume, right? Okay. So faster the breath, less volume. To attach that breath, I'm going to be more resistance, and I'm not going to be able to achieve that volume. And the goal for me, again, is volume. So for my pneumonia patient, my post-COVID patients, volume is going to be the key. So nice, slow, deep breath.
Tell my grape story.
Go ahead.
So that's considered a hyperinflation therapy, and I could have told you my grape story during CPAP and BiPAP too, but this will give you a real clear understanding of some of this processes using hyperinflation. So our lungs are just like the grapes you buy at the grocery store. The only difference is you've got 60 to 100 million alveoli in there, or we'll say grapes. So as we get older, simply because we're not as active as we were when we were 20 or 30. And then on top of that, through the years, you add on colds and flus and fumes at work and smog and fog and all that other good stuff. What happens is a lot of these grapes start turning to raisins. So when that starts happening, that's when we find that from here to the door, I got to stop halfway to catch my breath because all my grapes ain't working. So what we do is, so that's when we find we need oxygen. Why do we need oxygen? Because the grapes over here that are still working, they need help because these slackers over here, you know, they're not pitching in. So, and that's just a natural occurrence. And like I say, so you add on age and inactivity and so forth and so on, COVID, you add all that stuff on. So what happens is any type of hyperinflation therapy, such as the IS or PAP or any of them, some of those can be popped back open. And so now we pop the raisins, some of them, back open to grapes, and we call it recruitment. We actually have therapies that we can do on ventilators to try to encourage this mechanically. So, you know, they were right in telling you, you know, what you need to do. So and lots of folks have those from where they've had a surgery or something, because they encourage you to do it after you've had surgery, because under any type of sedation, even when you're on mechanical ventilation, you're going to have some degree of atelectasis occur. And so what they're trying to do is counter that with the IS after. So if you have one at home from previous, it's not going to hurt you to keep using it. I have a stationary bicycle at the house that I drive or ride, and I'm sucking on mine the whole way. A long time ago, I was a smoker, so I know one of these days I might have to pay the piper, but I'm trying to put it off as long as I can. It's a good piece of plastic. Definitely use it if you have one.
I see it more, or I used to see it more with open heart patients.
Exactly, because typically with that case, it's because they were under sedation for an extended period of time. And usually when they come out, they're on the pump and all that, and yeah.
And I think too, with this, a lot of the patients don't like it because inadvertently it makes them cough, which of
Right.
course is a good thing.
Right.
But when you've just had a major surgery or something, they don't want to cough.
Right.
So then, it's kind of a hit and miss. So I'm always telling them, like, well, coughing isn't a bad thing. It might not be comfortable, but it's not a bad thing.
In the normally, you're going to, when a patient gets an IS, you're going to encourage them to do 10 breaths every hour. It's not happening unless you're there to babysit them. It's just not going to happen. So what we would do in the LTAC anyway, we would, because 9 out of 10 of your patients are laying there watching television, what we would do was encourage them to, when a commercial came on, grab it. Even if you just do 2 or 3, that's fine. One is better than none. So, like I said, we use that psychology, and you would walk down the hall and you'd notice they actually would do it on their own sometimes, versus once every hour or 10 times every hour, just not happening. Okay.
Okay, so again, who's it indicated for? As you mentioned, post-operative patients. Patients with limited mobility, weakened non-obstructive cough. Patients diagnosed with atelectasis, pneumonia, or COPD. Now again, why do nursing homes why do post-acute facilities like an incentive? It's a very cheap modality with very effective if it's done frequently and done appropriately. The cost benefit of this is significant. For pennies on a dollar with this, if you are being a good cop on the beat and make sure your patient's using it correctly, the benefit to them is tremendous. And the return on that investment is also tremendous for the facility and for the patient. So I can't encourage you enough to make sure that your patients have this, that you encourage it and make sure you're doing it correctly though. Who can do it? Physical therapy, occupational therapy, respiratory therapy, and nursing. Whose job is really to make sure it happens? Nursing, right? But again, who should be performing this mostly without this coach? It's your patient, right? This is a great self-management tool. As Ray mentioned, the more that you encourage them to do it, the better. So your job is to make sure that you go and encourage them. Every time you engage that patient, as CNA, as LPN, RN, you engage that patient, hey, Bob, did you use your SIM today? And again, last thing here on my part, everything we've covered, everything from CPT, postural drainage, incentives, acapellas, they're meaningless unless we do this. So again, we really have two primary cough techniques in this environment that we really reinforce that go along with the modalities we've talked about. One is the forced cough. That's the most natural cough. I want you guys to do this with me. But that forced exhalation, usually Kathy, take a deep breath. Okay, hold it. Then proper etiquette when I cough is what? Cover my mouth, right? So again, we always encourage our patients, especially in the world of COVID now, cover our mouth. Deep breath in. Cough. Forced cough, right? One more time, everybody. What's your name?
Stacy.
Stacy, okay. And Katoya, right? I got that right. I'm proud of myself.
Yeah, I know.
Katoya, okay. So again, deep breath in. Okay, now I don't have Mary. I know your name, so I'll call you next. Do a forced cough for me. Okay, good. Now later on the corner, I know your name.
Emily.
Emily, I'm picking on you now. Give me a forced cough. Okay. Now I picked on Kathy, and I'm gonna pick on her sidekick here. What's your name?
Sandy.
Sandy? Glad to meet you, Sandy. Okay, now I'm pick on Mary again. Mary, example when you do the deep inhalation, I want you to breath hold for me, okay? Deep breath in, breath hold, yeah, deep breath in, hold breath, now forced cough. Okay, great, I don't know your name. What was it again? Sorry, your mask up like the long range. Okay, do me a favor, take a deep breath in, breath hold, Force cough. Okay, good. No. All right, the next one's going to be our huff technique. Huff is real simple. Again, deep breath in. Then we're going to really connect laughing. Ha ha ha. Ha ha ha. So if I have a patient that can't do just like laughing, right? Like Santa Claus, just Santa Claus, okay? So if those patients don't have a good force exhalation effort, we'll use the huff technique. So again, I didn't pick on you yet. What's your name?
Amber.
Amber, okay, Amber. Deep breath in. Breath hold, then we're going to do a huff technique, okay? Huff with me. Okay. This caused Mary laughed at you. Mary, you're next. Deep breath in. Deep breath in. Breath hold, then huff. Okay, Emily now. Do it with me, Emily. Deep breath in, breath hold, and huff. Just because like seeing your name, Victoria. Huff technique. Deep breath in. I haven't pictured your sidekick yet. What's your name?
Juanita.
Lazia?
Juanita.
Juanita, okay, Juanita. Deep breath in. I want you to force cough for me. Deep breath in. Right. Okay, now I forgot your name. Stacy, okay, stay with huff technique for me. Deep breath in. Okay, Kathy, do a huff cough for me. Hey, you had COVID. I'm gonna charge you for this because you had COVID. Deep breath in. Breath hold. Huff. Okay. Who could reinforce these techniques for a cough? Everybody, right? Everybody should be responsible for this. Now, back 14 years ago, I had a chain in North Carolina that we had a study. Every morning, their CNAs go into the patient's room, and what they did, they encouraged cough. Every morning, they go in to get them ready for their morning ADLs, shower, whatever. First thing they did was have them do a cough for 2 minutes. Okay, again, because again, they had a high incidence of pneumonia going out of the building. So again, they were trying to figure out ways, simple ways to resolve that. Two things we did: incentives and cough. We found the most effective was cough. When we lay in bed at night flat, what happens? Secretions. They pull right in the lungs, right? And we're at lower. Gravity tells me the basal segments of the lungs, right? Basal segments. So if I'm gonna clear the lung segments without being invasive, cough is my best friend, right? So again, hyperinflation, lung filled and cough, trying to be the best bet for that building, for those buildings. Over 30 buildings, they did that, and the rates of pneumonia transfer out of the building for pneumonia went down to about 10%. Just from that simple to every morning activity. Set spirometer during the day, and then cough in the morning. Again, just pull secretions at night, you mobilize them right in the morning. How many times in the morning you go down the hall and you hear the patients coughing and hacking up their emissions basin or the toilet or the waste sucker, right? So common sense tells you, give them cough first thing in the morning, they're going to clear secretions, and so it'll be something for the day. So again, combine that with you bashing over the head every couple hours with this, and encouraging cough every time you do it. Cough is your best friend. Everything else we do is meaningless, and give them a cough. So if everything I just discussed with you, cough is the most important technique.